Good morning. Very nice to meet you. Thanks organizers for inviting me to join the conference. First time ever for this RSGDREAM. So today I'm going to talk about the method that we have used for predicting the anti-PD-1 drug response using the decision tree models. So I represent the team called NetPhar. So basically we're a group of researchers from the University of Helsinki, far north in Europe, coming here. So let's give me some like a general introduction to cancer medicine. So basically now we have like a major cancer therapies, which can be categorized into 5 classes. Nowadays, we're more enthusiastic about the efficacy of targeted therapy and immunotherapy. But as a general rule of thumb, that we don't necessarily have the efficacy for each of the cancer patients, especially for targeted therapy and immunotherapy. And more striking is that actually we don't know too much about why certain patients don't respond to the treatment. So that's why in the precision medicine, if we want to fulfill a promise, then we have to solve the following questions, basically summarized into 4 general questions. So we have to identify who are the non-responders, and then why patients develop drug resistance so easily. And from the pharmacological point of view, we also need to understand the target of the drugs. And with all the knowledge that we have accumulated, hopefully we can develop a more effective cancer treatment. So particularly about this DREAM challenge, as mentioned by the organizer, is unique and it's never happened. So that's why, because the wisdom of crowd hits the wall of the data protection because of the patient data that was specific and sensitive. So in this particular DREAM challenge, we are focusing on particular lung cancer subtype, which is called non-small cell lung cancer. And we have to predict the immunotherapy response on the first line treatment, meaning that those patients are not treated previously. And we have to predict only the efficacy of the anti-PD-1, but not the chemotherapy. So we don't want to predict the general responders. And we don't have the training data, so that's why we have to try ourselves. So then we have to go to the PubMed, for example, literature. But the literature has a very heterogeneous type of data. We have multiple cancer types, heterogeneous disease stages, and unharmonized clinical protocols. So can we really predict something that we cannot have access to it in data protection? So basically, then I think the winning model or winning strategy is trying to derive a robust or transferable or even causal model, which can be used for predicting something that has never seen before. So I think this is also a very good case study for test the AI as compared to human intelligence. So how likely AI can detect the causal models. So our strategy is mainly from like an expert knowledge point of view. We want to build a model based on existing consensus knowledge. So as we know from this figure that was published just a year ago, they found out that the tumor mutation burden is associated with new antigen production. And in the meanwhile, the PD-L1 is used as a clinical biomarker. That motivated us that we have to include these 2 parameters into our model as the major effectors. And we also have done some text mining of top predictive genes from those existing data sets, and we have selected 10 predictive expressed genes. So how to build a model that maximize the optimization efficiency? Because we allowed only 5 submissions per sub-challenge, and only the final submission will be counted. So ideally, we should have a model which can allow this instant feedback from previous submissions. That's why we decided to utilize decision tree models, as they allow pruning the trees incrementally. And more importantly, a decision tree model can bear a strong interpretation that can be easily applied in the practice cases. So as a starting point, we need to identify the roots of the decision tree model. So as we mentioned earlier, so like DMB and PD-L1 are major effectors. So we have to choose between the 2 candidate models, which should be the roots of the decision tree. So then we rely on some existing data. We go to the Brown data set, which was published a while ago, and try to test some of the hypotheses. So basically, we want to predict the patient decision survival, and here we apply a technique called the grand rank, try to turn this patient survival status into a continuous variables so that they can predict using typical regression models. So the result shows that the TMB seems to have a stronger effect than the PDR1, as shown by the stronger p-values. And also we found an interaction effect between TMB and PDR1. So that motivates us to have this baseline model. First, by utilizing the TMB as a category, as the root of the decision tree, and followed by the PDR1 as the continuous predictor. So that if you have a higher TMB, then you should use the PDR1 as a predictor for the anti-PD-1 therapy response. But if a patient has a very low TMB, then that means the patient is not going to respond in any way. So this is our baseline model. And surprisingly, actually, we submit the baseline model to the PFS, which is the progression-free survival prediction. And it turns out to be the winner of the submission. And so that's what motivates us. Well, so what happened to this arm? Because we don't have any prediction, right? So that's why we want to still improve the model. But because we have only 5 submissions, so that's why we have to be very smart, not risk any predictions. So that's why we want to improve it only by testing the OS prediction and the BOR prediction. So, but of course, you have a risk if you decrease the model performance, then you will lose the challenge. So actually, to our surprise, we have tried different variables by try to add into this arm different additional variables, including the smoking, gender, and some of the predictive biomarkers derived from the literature. And actually, none of them is working. So kind of frustrating, because I think that's probably the trick to improve the model by improving the arm of this resistant part. So actually, this is why if you go to check our website, because each of the team needs to report their method in the web link. So we put the name this in end by the linking part, because it just shows our how frustration we are. Like we have to try so many things, but none of them doesn't work. So, but yeah, you can find more details from this challenge right up. So, but encouragingly, actually, we found a paper just was published several months ago in JAMA Oncology, which has independently validated our model using a much bigger cohort, which contains more than 1,000 patients in this advanced non-small cell lung cancer. So if you go to the paper, it exactly has the same conclusion as we have proposed as a decision tree model for the anti-PD-1 treatment response. So it's pretty encouraging, and I hope this that's why the significance of our model is such that we found out that, as I said earlier, we need to find a causal model, ideally, so that the model can be transferred from different data sets. So we found that the TMB seems to be the first cause for anti-PD-1 treatment efficacy. So if a patient does not have a TMB mutation profile, then most likely the patient won't be responding to anti-PD-1 treatment. And if you look at this decision tree, it's simple, but it's very predictive. That shows the promise that you can apply this decision tree model in actual clinical patients. And then it's coming to the research question. So we still want to try our best to improve the prediction, because because of the limitation of the data access, we cannot test so many hypotheses. But I think ideally we should do something about those patients who don't have the TMB high profile. We still can develop some, for example, synergistic drug combinations, which can be used to sensitize in the patients to the immunotherapy. So probably that will be something that we will further develop. So my time is up. And also acknowledgements. So of course, nothing can be done without the support, especially from the organizers and also from the founders. So I would be very grateful if we will still get